Hello everyone, this is Dr. Pruett. Today we're going to be talking about anaphylaxis. This is one of my favorite emergencies and I'm excited to talk to you about this today. To start off with, I've got no disclosures. Here is the plan ahead. The definition of anaphylaxis: severe, acute, potentially life-threatening allergic reaction. Okay, so where anaphylaxis came from is Charles Richet in 1913 was a French physiologist who was studying the immune system, and one of his studies involved injecting his dog with sea anemone toxin to see if he could make his dog immune. So the first injection reportedly went fine, and the second injection, the dog had a massive reaction to the injection and got incredibly ill. Now, I know you're all wondering, how did the dog do? Unfortunately, I don't have an answer to that, but I do have a suspicion that the dog probably didn't survive. However, Charles Richet made a very important discovery that upon a second exposure to an allergen, there can be an overwhelming response by the body, and he called it aphylaxis. And he went on to study this in further depth and eventually won the Nobel Prize in Physiology or Medicine in 1913 for his discoveries. So when we think about the immune system, it's a pretty complex and amazing system. It gives us very good advantages for fighting disease and fighting cancer, but it's a very delicate system. And if there's not enough of it, you can obviously be susceptible to terrible diseases or to cancer, and it's not impenetrable either. But if there's too much of it, this can also cause problems as well. Autoimmunity, leukemia, lymphoma, and allergy is one of the things that we think about with too much of an immune system reaction. So it's a very delicate balance and a very incredibly delicate system. When we talk about anaphylactic reaction, what's going on at a physiological level is, if you look at the antigen here, pretend this is either a protein on a peanut or maybe a protein on a piece of grass that you're allergic to in the summertime. As our body's exposed to it for the first time, it comes in contact with our B cells that are constantly surveilling our bloodstream. When this B cell comes in contact with this invader, it recognizes this as a foreign entity and kind of puts the rest of the immune system on alert. So it puts these little receptors on all of the cells that it's coming in contact with to be alert for this invader the next time it shows up. And so that on the subsequent exposure, when that same antigen or same protein comes into our body, our immune system's ready for it and is ready and primed to attack. So it binds to that receptor on the outside of these mast cells and releases these granules called histamine. And this histamine has a very profound reaction on the rest of our body. So what happens when the antigen, on this slide it's green, when it binds to the mast cell and the histamine is released, it causes itchiness in our skin. It causes contraction of the upper respiratory airways. It causes blood vessels to dilate, and it causes gastric acid secretion. Now, when you look at what it's doing, there's reasons why for all of this. So if you think about the gastric acid secretion, it's causing acid to be secreted because likely this antigen came into our body from our stomach or our mouth, and it's using the acid to kill it. By dilating blood vessels, we're bringing more blood to the area, which brings more immune cells to help fight the invader. By contracting the airways, again, that's an unfortunate consequence of bringing more blood to the area to fight the invader. We'll talk about the lung pathophysiology here a little bit more in a minute. And then with the skin, same thing. That's just a consequence of increasing blood flow and the histamine release, which in and of itself causes itching. So there's two big problems when we think about anaphylaxis. There's an obstructive airway process that leads to airway constriction and mucus production. And then there's a distributive shock component as well, the vasodilation that leads to hypotension, decreased blood pressure, and swelling peripherally with decreased blood return to the heart. When we look specifically at the lungs, this I think is pretty interesting, and it's a very similar process to asthma actually. When you look at the airway here, on the left is a normal airway with the red circles indicating the arteries and the blue circles indicating the veins, doing normal oxygen exchange with ventilation just like normal. Nice big airway in the middle with just a little bit of mucus to clear the bugs, and lots of room for air exchange. But if you look what happens when our body's reacting to something, this area in between where the blood flow is occurring gets really swollen and creates a ton of mucus. And the only way for the airways to swell is towards the middle. And the consequence of that is that the airways get very small and very tight. And that's what causes wheezing. If you look at this even closer, this is a pathology slide of a lung underneath a microscope. If you look on the left here, this is a normal lung with lots of white space and very thin cellular layers with essentially just one layer thick of cells to do oxygen and carbon dioxide exchange and very efficient air movement. If you look in the middle, you'll see one of the bigger bronchuses there with, again, a large lumen, not much mucus in between, not many cells, lots of room for air to come and go. But if you look over on the right in a constricted lung, again, this could either be asthma or anaphylaxis. There's a ton of cells in there. There's not much room for oxygen exchange, and the airway is much more swollen and narrow than normal because of the edema and the extra cells that are in there acting in a very inflammatory way. So who cares? Well, if you ask me, this is the quintessential emergency. I honestly think there's maybe 3 emergencies where in the pre-hospital setting we can absolutely independently save a life. And this is one of them. By getting epinephrine to the scene early and recognizing this emergency, we can make a huge difference. The other ones would be Narcan in an opiate overdose and a tourniquet in a bleeding patient. So if we start with a scenario, an elderly gentleman who's stung in the hand by a bee, the hand swells up and he has trouble breathing. Would you define this as anaphylaxis? Well, according to the World Allergy Organization, they define anaphylaxis as an acute onset of skin or mouth symptoms plus wheezing or hypotension. They also have a caveat where it could be reduced blood pressure after exposure to a known allergen, much like Will Smith here. I'd like to keep it a little bit more simple and just think of it in terms of 2 systems. If there's 2 systems involved, then it's anaphylaxis. That could either be skin, respiratory, cardiovascular, GI, or neuro. If I can convince myself that there's any 2 symptoms involved, then I'm going to call this anaphylaxis and I'm going to be giving epinephrine. Now, there's a lot of systems to choose from. So if we think about it, the signs and the symptoms that we might look for, on the skin, obviously, we all know about the hives and the swelling and the itching. The skin might be flushed and red as well. With respiratory involvement, you can hear coughing, wheezing, shortness of breath, hypoxia, chest tightness, congestion, watery nose and eyes. And then with gastrointestinal, as we discussed earlier with the increase of the gastric acid, this can cause nausea, abdominal pain, stomach cramping, vomiting, and diarrhea. It's really important to consider gastrointestinal as a possible route of allergy manifestation, especially in children. Frequently, they're the ones that are going to present with skin findings and nausea, vomiting, or diarrhea, and it's easy to miss if you're not thinking about it. Cardiovascular can manifest as dizziness, lightheadedness, palpitations, tachycardia, shock, and hypotension. And then don't forget neurological manifestations as well. People might feel anxious, feel a sense of impending doom. They can be altered, confused, or complain of a headache. It is a spectrum of disease, and a lot of how severe the reaction is how robust is dictated by how robust the immune response is. But it can lead to death. So I know as a physician, I frequently am looking in the back of people's throats to see what's causing their sore throat. But this is a picture of what a mouth looks like. And any allergic reaction patient, I always look back there to evaluate how difficult their airway is going to be. So what you see here is the uvula hanging down in the middle. You want to see it in the middle, and you want to see it not too swollen, so this looks normal. You see the tonsils over on the side. Those look normal as well. the tongue. And since I can see a good amount of the posterior oropharynx here, I'm telling you this is probably not going to be that difficult of an airway, which is going to help me breathe a little bit easier when I'm thinking about a potential airway emergency. Now, as I'm evaluating that airway, I'm thinking about other red flags in these patients. And if I hear them wheezing audibly, I'm going to be concerned about respiratory involvement. If I hear stridor, that's really going to make me nervous. And if they're drooling or have a hoarse voice, all of those things are indicators of an impending airway emergency, and I need to start thinking about cricothyrotomy. Now, the most common cause of allergic reaction is food, medications, and insects. And as more and more of our food is becoming processed and chemically altered, we're seeing more and more allergic reactions to these foods. Now, how frequent is this emergency? It happens about 1 in 1,000 people per year. So that's 2% of the population has an allergic reaction every year. And why is this important? Again, why it's my favorite emergency, because it's 50% of these fatalities occur in the first hour. And who's there in the first hour? It's our pre-hospital providers. So we need to know this emergency backwards and forwards and be absolutely prepared to treat it. In this day and age, it still amazes me that about 1,000 people die per year of this when it's so treatable. Another very important point is that skin and mucosal signs are going to be completely absent in up to 1 in 5 of these patients, up to 20%. So just because you don't see hives or you don't see the red itchy skin, don't think this isn't an allergic reaction. You need to be thinking about it in the back of your head if you have that nausea vomiter with hypotension and a known allergy exposure. So, as I mentioned before, our treatment's going to be epinephrine. I hope you guys remember your dose. For adult, it's going to be 0.3 of the 1 to 1,000 IM. Now, I don't know about you, but I'm terrible with numbers. So the way I remember this is that our dose is 0.3, and the 1 to 1,000 has 3 zeros behind it. So the 2 3s in my mind go together. You do whatever you need to do to help yourself remember that, but that's my little trick. It's fine to repeat that dose every 5 to 10 minutes if your patient isn't getting better. I can tell you that if I'm drawing up my second dose in a patient who's not improving, I'm getting ready to start a drip. And in terms of pediatrics, your dose is 0.01 mils per kilogram, again, 1 to 1,000. And your EpiPen dose, which will usually be safe, is for most of your little kids, will be 0.15 mLs. And same thing, continually reassess. If they need another dose, it's okay after 5 minutes. I had a boss tell me one time you can either give this very small dose of epi before they die, or you can give them the massive dose of epinephrine after they code. And I would much rather give this little tiny shot from a TB syringe, personally. A little bit more literature about anaphylaxis. And it's not so great for the medical community. Actually, it's a little embarrassing. But one of the reviews from this World Allergy Journal shows that only 25% of the cardiac arrests that were due to anaphylaxis received epinephrine prior to their arrest. That's 1 in 4 patients that were missing. Patients that are more predisposed to poor outcomes are older patients, patients who are on beta blockers, and patients who have a history of asthma. And if you think about it, those kind of make sense. The beta blockers, we're giving epinephrine, which is basically like a shot of adrenaline, and the beta blocker is, if it's on board and active, is going to decrease the efficacy of our adrenaline because that's what it does. So these patients might just need higher doses or more frequent doses to overcome that beta blocker effect. And then asthma makes sense too when you think back to those pictures of the lungs. Those lungs are already predisposed to disease and to swelling, and the allergy is going to make it even worse. But the number one cause of poor outcomes is actually the failure to use epinephrine. This is an article from Resuscitation in March of 2017. It was looking at about 500 cases of anaphylaxis in British Columbia. And it was asking the question about epinephrine use in elderly patients. And there was actually no complications from IM epinephrine use in patients that were older than 50. So a lot of people are afraid of epinephrine because they think it's going to explode the heart or cause a heart attack. But again, it goes back to that saying, you can either use it before they die or after they die, and it's a much safer dose before. And we know that it's safer in older patients now. So once you've defined anaphylaxis in your mind as those two systems being involved, and remember it's any two systems, once you've convinced yourself of that, then you're going to give epinephrine. That's when you know to pull the trigger. Now, how do you give it? Here's another embarrassing study. This Annals of Allergy and Asthma and Immunology in 2015 was looking at medical device administration, and there was an 84% EpiPen error rate. Now, so that we don't make the same mistakes, I want everybody to know how to use it. The blue goes towards the sky, and make sure your thumb is not covering the orange part. There's 10% risk of injecting your finger with the medication and missing the patient completely. So make sure when you hold it, you hold your thumb against your fingers and not over the top of the injector. And make sure you've taken the cap off before you inject it as well. And then use enough force to engage the needle. And I think one of the most important things about this is once you've engaged the needle and it's penetrated the skin and you haven't injected your thumb, make sure you hold the device in place for at least 10 seconds so it can completely administer all the medication. So what exactly is epinephrine doing, and how is this the cure for anaphylaxis? Well, basically it activates the sympathetic nervous system. So that's our fight or flight response. And when you look at what it does, it directly acts against everything that we talked about the mast cells doing. So it's going to inhibit salivation, it's going to decrease gastric acid secretion, it's going to increase blood pressure, and it's going to open up the lungs and cause bronchodilation. So everything that immune system is trying to do to fight that invader, epinephrine is going to counteract and cause the cardiovascular system and all the other systems to get better. Now, there's other things that we can give in the hospital, or some of these on the ambulance to help the patient get better. Antihistamines make sense, right? We have a massive histamine release that's causing this problem, so we give antihistamines, and this mostly just helps the patient feel better. This is either Benadryl or Pepsid. We can give steroids. Again, this is just another way to decrease that inflammatory response. Fluids might help with a hypotension, and albuterol might help if you have a patient that's wheezing. Now, a very important point here is if this is caused by an insect, don't forget to remove the stinger or the offending agent. So if you have a patient who's allergic to paint, say, get the paint off. Or if you have a patient with the stinger in, get the stinger out. You need to remove them from whatever is triggering that response. I remember one time I was in a country in South America, and this guy who was trimming trees was attacked by a swarm of killer African bees. And he came in anaphylactic shock to the point where we needed to start an epinephrine drip. But it took me about 30 minutes to get all the stickers out of him to stop his immune response. So what I want you to take away from this talk is that ask yourself how many systems are involved. And if you can convince yourself that there's two, it's anaphylaxis. And once you know that you are dealing with anaphylaxis, don't be afraid to give the epinephrine. And here's my references. Please feel free to contact me or your 7-8 if you have any questions.